Hi, my name's Gal Dadlani. I'm a pediatric cardiologist at Memorial Children's Hospital in Orlando. And our topic today is pediatric cardiology cases for the general pediatric clinic. Would we refer or not refer? Our objectives today are to identify patients within your pediatric practice who are at risk for occult cardiovascular disease, and to be able to describe the most common causes of sudden cardiac arrest in pediatric patients and young athletes. Based on the American Heart Association's recent data, 1 out of 3 Americans will die of cardiovascular disease. Leading causes will be coronary disease, stroke, high blood pressure, heart failure, and diseases of the arteries with that. As pediatricians, your job is ever important because this summer, more than 7 million student athletes will have annual physicals prior to sports pre-participation. So we wanted to make sure that you were aware of occult forms of cardiovascular disease and to be on the lookout for these as you're performing these pre-participation sports physicals. When you look at the most common causes of sudden cardiac arrest, hypertrophic cardiomyopathy consumes over 40% of those and is the leading cause of sudden cardiac arrest. The other causes are listed there for you on the slide with that. Based on the American Academy of Pediatric policy statement on sudden cardiac arrest, they list common disorders for sudden cardiac arrest. And again, hypertrophic cardiomyopathy is listed as number 1, coronary artery anomalies are number 2, and then other ones are listed down there for you with it. When you look at athletes that participate in sports and are at risk of sudden cardiac arrest, there's no high school longitudinal study that assesses that risk. There is, however, data by the NCAA looking at college athletes and their risk based on each individual sport. This article was published in 2011 by Dr. Harmon, and basketball players were at the highest risk, followed by swimmers, lacrosse players, football, and then cross country with that. The American Academy of Pediatrics recommends for pre-participation sports physicals that those be done during a well-child visit. And they advocate against doing mass physicals because of the loss of being able to take an adequate history during those times. If you are doing pre-participation sports physicals, you want to keep in mind assessing their heart health, their mental health, giving them an overview of concussions and head injuries, and for female athletes also their menstrual health, bone health, and nutritional intake with that. The American Heart Association has a 14-element checklist anytime you're doing a pre-participation sports physical, and these include a comprehensive personal history, family history, and physical exam with that. So if we can use that 14-element checklist on our patients, we can always make sure that we're assessing for occult cardiovascular disease. So now let's do a few cases to look at how we can utilize this 14-element checklist. Case number 1, we have a 16-year-old male who is running a 400-meter dash and during the event develops chest pain, 5 out of 10 intensity, that he describes as a tightness in the central chest. He reports 1 or 2 similar events during recent practices. He denies a history of asthma. He denies a family or personal history of cardiovascular disease. And on your exam in the office has normal vital signs and a physical exam. Based on that 14-element checklist, what would you do? A, I would observe and not refer. B, I would obtain an EKG. Or C, I would refer to cardiology. When we look at chest pain in children and in the pediatric population, most forms of chest pain are not non-cardiac in nature. This was a study from Boston Children's Hospital where they looked at chest pain patients coming into the emergency room at Boston Children's, and less than 1% had cardiac-related chest pain, so 99% were non-cardiac related in this study. Of cardiac-related chest pain, the most common cause presenting to an emergency room will be pericarditis based on this study with that. If we go back to our patient, the child that was running the 400-meter dash and developed chest pain, he had chest pain with exertion. And based on our 14-element checklist, that would be a trigger within a personal history to refer for further cardiac testing with that. When this child was worked up, he had a normal EKG, which is attached over there. And you can see on the screen, based on his echocardiogram, it was difficult to see his right coronary artery. So he subsequently went for a CT scan, which demonstrated an anomalous right coronary artery that was between the two arteries. So as this patient exercises and he develops higher blood pressures with exercise, that right coronary artery can become compressed. On the image, you can see there as the right coronary artery lives between the aorta and the pulmonary artery and can cause chest pain, myocardial infarction, or even sudden cardiac arrest with it. Now let's do case number 2. And again, we'll continue to utilize that 14-element checklist here for us. So case 2, I would refer which of the following teenagers for a cardiology consult? A 14-year-old male who's in ROTC running laps and collapses during mid-exercise. B, a 12-year-old female who collapses during a blood draw in the office. C, a 15-year-old female who competes in a 400-meter race and is standing talking with her coach after the race and becomes dizzy and collapses. Or D, I would refer A, B, and C. So if we take these patients and look at syncope in the pediatric population, syncope is very common in the pediatric population. Approximately 35% of children will experience at least one episode of syncope. And unlike in adults, most causes of syncope in children is typically benign. And vasovagal or neurocardiogenic syncope is our leading cause of syncope in this age group. Most cases of syncope that present to the emergency room in this paper from 2014 present either during a bathroom, at home, or in a classroom as they have vasovagal related symptoms with it. If we go back to our 14-element checklist and look at the cases that were presented here in case number 2, unexplained syncope, especially with exercise, is a high-risk event. So when we look at this list, the 14-year-old male who's running a lap and collapses during mid-exercise or peak exercise is the most important one for us. Case number 2 that has a 14-year-old collapse during a blood draw is typically a vasovagal related event. A C, a 14-year-old who completes a race and then is standing talking with her coach and then becomes dizzy, again, is a vasovagal related episode as the blood is starting to pool in the legs as the patient's standing and with being hot and sweaty after exercise. So the correct answer for this would be number A, and collapses during exercise. That patient, upon workup, had catecholaminergic polymorphic ventricular tachycardia, which is a rare form of an arrhythmia, but can be a cause for sudden cardiac arrest. In this case, as the patient develops increased adrenaline levels with exercise, that induces ventricular tachycardia from the lower chambers of the heart, and that can lead to syncope and or sudden cardiac arrest with that. That is genetically inherited and can be dominant in families, so first-degree relatives do need to be screened for those patients. And you can do genetic testing to look for the proteins that cause this. So in summary, I hope that these 2 examples show you how that you can utilize the American Heart Association's 14-point checklist for pre-sports participation, and hopefully you can utilize this in your clinical practice to save a life. And I thank you for the opportunity to speak here today, and have a great day.